This is a post-traumatic anterior subluxation of the IOL bag complex. This lady was operated by me 15 years ago with Technis multifocal three-piece lens. 5 months ago, she came to me with a grandchild had hit her eye with a toy and resulted in anterior subluxation of the IOL bag complex. So let us see very simple procedure how I manage this case. I start by creating two side ports because I want to inject viscoelastic. Now, few points to remember here are whenever you inject viscoelastic in a case of subluxation of IOL, the viscoelastic has to be very gradually instilled into the anterior chamber. You will notice I'm using a 27 gauge cannula to inject methyl cellulose. I slowly inject methyl cellulose into the anterior chamber, making sure that the pressure of the anterior chamber is raised very, very slowly and gradually. And the end point is the moment the serpents of the viscoelastic being created in the eye disappear and the iris moves backwards. Now, I will go in with one instrument, which is a wire rotator instrument, and in a very, very controlled movement, try and slip and slide this IOL bag complex behind the iris without causing much pressure downwards. Now we will see that in the reverse and the slow motion. I go in, I hold the edge of the bag, push it in, and as the bag IOL complex starts sliding in, then I take the force towards the haptic and ensure that the haptic slowly slips behind the iris without any extra pressure and dislodge of the vitreous. Now I will use again that wire rotator to engage the capsular access margin and push the subluxated IOL complex downwards. You will notice that there is no free movement of the IOL bag complex, which ensures that there is no vitreous in the anterior chamber. Then I manipulate the iris also to look for any tags of vitreous. Having realized that there is no vitreous there, now instill a small amount of pilocarpine or a carbocol as a meiotic to make the pupil small. Now to remove the viscoelastic from this wound, I have a choice of using a bimanual irrigation aspiration, which I will avoid in this case. So I use a method, favorite method in such cases or cases where I suspect some vitreous in the anterior chamber. I use a 27 gauge cannula, give short burst of fluid, and while I give the burst of the fluid, I dip the scleral lip to make sure that the fluid keeps coming out. So this ensures that there is no increase of intraocular pressure. You will notice that this small burst of fluid will keep getting the viscoelastic out without giving any increased sustained intraocular pressure in the increase in the anterior chamber. And you will notice I'm able to remove most of the viscoelastic just by this simple technique. If I would have gone with a bimanual irrigation aspiration, I would have gone in with the fluid and probably caused increased pressure in the anterior chamber and caused some vitreous to be disturbed. This way, everything is controlled and I can stop at any point I want and I come out of a sealed wound. In case of using a bimanual irrigation aspiration, the side ports need a good amount of hydration, which again is avoided by using this method of removal of viscoelastic. This patient post-operatively had 6 by 9 unaided vision and has been maintaining a continuously perfect vision post that day. So this is again one simple method of doing such a case. Thank you.